Thank you. As we just saw in the video, non-communicable diseases don't only exist in wealthy countries. 36 million people, maybe even more, this year perish annually of non-communicable diseases, and almost 80% of them die in low and middle income countries. Non-communicable diseases are the leading cause of death on every continent but Africa, and by 2030, if current trends continue, they will also be the leading cause of death on the African continent. Dr. Chan, I want to start with you. From your perspective at WHO, how are you changing the ways in which you engage governments, particularly in the developing world, on questions around non-communicable diseases, while so many are also still struggling with existential questions of HIV/AIDS, malaria, and communicable diseases more broadly?
Well, Chelsea, thank you for that extremely important question. But before I answer that, I'd like to thank you for the invitation and coming back to Clinton Global Initiative. You raise an important point. It's about the triple burden of disease in many countries, but especially in developing countries. The health services in many countries, they are structured and organized in such a way to deal with episodic disease, diarrhea, pneumonia. Now, more and more we are seeing more people in both developed as well as developing countries are being, affected by what we call non-communicable diseases, and these include, of course, heart disease, diabetes, cancer, lung disease. Now, these are chronic long-term care. The health systems in many developing countries do not have the human resource capacity, healthcare worker, that know how to deal with it. And they don't have the right kind of medicines or interventions for prevention, for early diagnosis, for treatment. So truly, this is a very important issue. And the statistics you have just quoted is really awesome. Awesome in a bad way. 36 million people in the world die of these diseases. And if I tell you, 14 million out of those 36 are what we call death before the age of 70. We call this premature death. And they are preventable, totally preventable. So, the big message for all of us is, how can we start and focus more on prevention across the board? It's not just prevention by the health sector, but we need to work with other sectors, transport sector, environment, education, to make sure that each and every one can contribute to the whole scheme of things about preventing disease and preventing suffering. And more importantly, if we do not address this, the cost, not only of care, health care, it is not affordable. US FDA, we know how good this organization is. They approved 12 cancer medicines. And out of those 12 cancer medicines, 11 of them cost more than $100,000 per person per year for treatment. How many countries can afford that? So go back to the most important messages, which is embraced by all countries in WHO. We have 194. I don't know how many bosses you have. I have 194 of them. And they all embrace, prevention is the cornerstone as a global response to NCD.
And are there, and I don't want to put you in an uncomfortable spot where you have to choose favorites among your bosses, but are there member states that you think are doing a better job of kind of having a holistic approach to health and not just confining it to the health minister?
Well, of course, Chelsea, you will never be able to put me in a difficult spot.
Oh.
No, because you are very smart.
I will try to not prove you wrong.
Because the interesting thing is, countries across the board, developing, they have still room to improve. But by and large, I think developed countries have done better than developing countries in terms of, tobacco control, healthy lifestyle, and also more exercise, promoting exercise. So there is a time lag for developing countries to catch up. It's not to mean that they don't know what is the issue. It's that, the government need to provide the enabling environment for ministries of health to work with others to keep people healthy.
And Risa, you're nodding. I mean, do you think it is a different dynamic in this country, or do you also think here we are struggling to make that shift? And are some cities, states doing a better job than others?
Absolutely. I think we're still struggling with how to acknowledge that in many ways we are blessed with the ability to make miracles in our healthcare system. But at the same time, it falls short because we often stay focused on just what happens within the hospital walls or the clinic walls or a doctor's office. And so often, in order for people to really get healthy, we've got to focus on more than just the illness and get outside of the hospital walls. There's a wonderful program that illustrates how this can happen that's called Health Leads, where you actually have advocates, often undergraduates who are trained, to fill prescriptions for things that go outside of the hospital wall and help people get healthy. So we know, for example, if people don't have heat, if they don't have transportation to get a prescription filled, if they can't get access to the healthy foods that they need to stay healthy, they're not going to get well. And if you write a prescription, as the person who founded this program, Rebecca Ani, taught these health advocates to do, to fill those needs, you can actually improve the quality of overall care that they receive and go further towards preventing the consequences of non-communicable diseases. So in our country, we've got to pivot, if you will, from just being focused on illness care to expanding that.
And Adrian, from a health insurance perspective, why do you think prevention is such a good investment? And how are you trying to encourage a broader base of participation from employers to help their employees and their employees' families get healthier and then stay healthy?
I think the fundamental issue with prevention, what makes it very exciting is that largely it's about behavior change. It's not about the complexity of healthcare and complicated healthcare interventions. If we get behavior change correct, then preventable illness is not eradicated, but certainly delayed. I like the Oxford Health Alliance 3-4-50 idea. 3 behavior types: smoking, poor nutrition, poor physical activity lead to 4 conditions: cancer, lung disease, heart disease, diabetes, that drive 50% of mortality. So if you can change that dynamic of those 3 behavior types, the effect on the healthcare system, the effect on people's lives, the effect on society, I think is remarkable. So as a health insurer, we were chatting just before the session, clearly what's good about this is there's kind of no trade-offs. If we can encourage prevention, it's good for us, it's good for the member, and it's good for society. And therefore our approach has been fundamentally about using incentives to create behavior change. And I think that is fundamental because behavior is a complex issue, and we're learning a lot from behavioral economists about this very complex issue that people don't act rationally. And the difficulty with prevention is that always, not always rationally, let me just state that clearly, but the complexity with prevention is that we know this unique, we call it a healthcare paradox, that healthcare is overconsumed, wellness is underconsumed. And when you go through the logic, it's quite simple. With healthcare, typically, certainly in developed countries, the price of healthcare at the point of care is usually zero. It's either covered by health insurance or by a national health system, but the benefits are immediate, and people feel that. Whereas with wellness, the price is immediate. You've got to go for that run you don't want to go for. You've got to stop eating the foods that you'd like to eat, and the benefits are 20 years down the line. So the kind of individuals, what health economists call hyperbolic discounting, they value the present, not the future, and they just avoid doing wellness activities. So changing that dynamic is fundamental, and therefore, in our view, focusing on behavior, focusing on incentivizing a change in behavior has such an amazing payoff.
And what incentives have you found to work?
We have found, look, in the context of wellness, there are so many different behaviors. Some are simple, some are complex. So in the area of screening and preventive screening, that is a fairly simple intervention to incent. To focus on obesity is more difficult. To get people to lose weight in a sustainable way, that's more complex. But we found typically across the entire spectrum, from physical activity to better nutrition particularly, we've been very successful in using subsidizing healthy foods, in effect. It's had a tremendous effect. We found that in our base, we've increased the percentage of the trolley that's healthy by 9%. But generally, I'd say to you that the ability to change people's behavior is doable with the right kind of incentives.
You know, Chelsea, I like to pick up on a very important point made by Adrian. You talk about diagnosis, and I would emphasize the importance of early diagnosis and early treatment. And while we were waiting in behind this beautiful stage, I heard about the important thing about the kitchen, school kitchen. And also, I mean, I use that as an example to bring into the concept of multi-sectoral collaboration. Early diagnostics must be provided by the big pharmas. You know, the pharmaceutical company come up with early diagnosis to prevent, for example, hypertension. If you treat it early, and the screening is easy, but what about diabetes? If you picked up early diagnosis, then you start taking care of yourself, either through more exercise, better diet, or you need to go on to use medicine, because the complication arising from diabetes is really horrific. You can get blindness, kidney failure, heart attack, and in some countries where you don't wear shoes, you can get amputation. So, I mean, the whole spectrum of things, you know, we need to engage other industry to bring in their contribution to attack and really reduce the burden arising from non-communicable diseases.
And so how is WHO engaging beyond the pharmaceutical industry? I know WHO doesn't work with the tobacco industry, but that you do work with, you know, the food industry, the beverage industry. You know, what are you in active conversation with them about? What do you hope to kind of see soon over the horizon?
Chelsea, you're right. The 194 countries in WHO is very strict, and they don't want to work with the tobacco industry because there is no safety limit in tobacco, and it causes so many diseases and cancer. But other than the tobacco industry, my member states never tell me not to work with the industry to find public health solutions. No government in this day and age can find all the solutions without public-private partnership. But in order to work with either the pharmaceutical company, the food and beverage, and even in the case of alcohol, it's interesting area. In WHO, we have 194 countries. In some countries, for other reasons, religious, culture, they don't drink, okay? But also in other countries, I mean, the culture is that they can drink modestly. So how can we find the right balance? Now, working with industry doesn't mean to be in bed with industry, but you have to have mechanisms in place to avoid conflict of interest, to avoid undue influence in policy setting as well as in standard setting. And I think, you know, we have proven over the years that we can work with the industry to find the right kind of solution.
Risa?
Yeah, can I jump in here? Because I think one of the ways that foundations and other NGOs can get involved is to provide new information that can reframe some of these thorny issues. One of the studies that comes to mind is one from last year where the Hudson Institute, working with Hank Cardello, really asked the question, do companies that have, food and beverage companies that have more better-for-you products in their portfolio do better? Can you do well and do good at the same time? And just to cut to the chase, when they looked across 15 or so companies with different amounts of better-for-you products in their portfolios, those that had more better-for-you products, as they defined them, actually had a better operating profit, enjoyed better reputations, and delivered higher value for their shareholders. So funding those kinds of studies and reframing the debate, if you will, and showing the ways in which business can build a healthier environment by doing what they do, which is providing products, it reframes the debate and creates an opportunity for us all to work together towards better prevention and healthier lifestyles.
Adrian, were you going to?
I think in our case, in our Vitality program, which is the program that we use that covers about 6 million people across 4 countries, its entire focus is on working in a partnership basis with sports apparel companies, with healthcare companies in the right way, but also with reward companies, airlines. We work with grocers like a Walmart here in the US through Humana. We work with Sainsbury's in the UK, cold storage in Singapore. So to an extent, the approach we've taken is fundamentally about partnerships, not just in the healthcare space, but essentially giving a sense our members a chance to utilize all different incentives to change their behavior. But I just want to pick up a point that Risa made. I mean, our sense of it and our data, which now I think is quite extensive, 15 years of millions of life years of experience, the actuarial data is very compelling. When people engage in these activities, healthcare costs go down, mortality rates tend to go down. And all of these studies about companies doing the right thing in terms of wellness, it seems to be one-directional. It all seems to be good. Now, I'm not sure the causality. There's certainly correlation, I'm not sure the causality, but I would say to you that we're at the embryonic stage of understanding the power of prevention. We're just scratching the surface, and I think one of the things we have to do, and we're certainly investing in that, is understanding the data, understanding the causality, and coming out with best practice to make sure that we do change society in the right way.
Risa, across all of the work that Robert Johnson Foundation has engaged in or observed, what have you seen to be the most effective in really not just encouraging one behavioral change, but encouraging sort of the complement of behavioral changes to move someone from poor health to good, sustainable health?
I would summarize it in 2 words: comprehensive and collaboration. These changes that Adrian has spoken about require people to make the healthy choice every single day. And the only way that you can do that is if making that healthy choice is easy. And that often means comprehensive changes in the environment. Having an environment that allows you to get activity is a part of your normal course of events. That means bike lanes, that means sidewalks that are accessible, that means crosswalks that have a light that's long enough for people of all ages to get across the street. It also means that you've got to have collaborations that exist beyond one sector. So the business sector working with government, working with NGOs, working with schools, that kind of comprehensive approach to policy and collaborations across sectors are the things that we've seen really work well.
Dr. Chan, I want to return to the question around what can developing countries do and what is it fair for their citizens to expect them to do, given how capacity constrained so many health ministers and other ministers are in the developing world? We were talking a little bit about this backstage, but what, from your perspective at WHO, do you think it is fair to expect developing countries to do on NCDs specifically?
Yes, in fact, 194 countries in WHO a couple years ago, with the help of many partners, including civil society, business, foundations, really raised the political awareness and political commitment, culminating in having a UN declaration on the world's response to non-communicable diseases. Now, having a resolution is important. Having political commitment is important. How do you translate commitment into action? That is a critical step. Now, the World Health Organization, working with our countries, have developed a global action plan on NCD between 2013 to 2030. Now, what does that mean? What does it take? So the countries themselves must first and foremost have a national plan and identify what are the diseases that are causing big problem in their country, and then develop a plan and then introduce affordable, quality interventions to prevent illness. And at the same time, those people that are already having illness, you need to provide early diagnosis, early treatment. If indeed some people unfortunately have cancer or stroke, rehabilitative service is extremely important. So can we, again, going back to what Risa says, to have a comprehensive package from promoting good health, preventing disease, treatment, of course, including early diagnosis and rehabilitation. So WHO is working with many partners, including Clinton Foundation, to provide the capacity building in countries, come up with a good plan, have the human resources, and as well as financial ability to prevent disease and minimize the impact. Because, it's interesting. The World Economic Forum and Harvard University did a study. In the next 20 years, if we don't take any action, the loss in productivity to the world is about $30 trillion. Now, I don't know how many zeros is in a trillion, certainly many. So $30 trillion. So what does that mean when the world's countries are talking about sustainable development? So we really need to factor that in. But Chelsea, may I come back to one point we can make? The important role of a civil society is really to make sure that, they hold the government to account and they hold all of us to account. But it is also, we should not be naive, that the industry, their objective is to make profit. My member states in WHO have no problem with the industry making profit. So we need to find the right balance. But I am seeing more and more companies who understand share responsibility, share value, and how can they work with government and to move the needles and begin to change things. I just came back from a dinner reception last night. I'm not supposed to tell you the company because I don't want to advertise for them. We are beginning to see CEOs of companies who understand the importance of share value and are really moving ahead. I asked them the question, why? Is that you can do good and make profit at the same time because more and more countries, their people are so sophisticated and well-educated. If you don't do it, you are behind the curve. You would be left behind.
Can I
Risa,
second that? Because we actually just did a survey of 129 business leaders, and it just confirms what you said, that they are recognizing that if they invest in prevention, and prevention that we know works, they will see an increase in their profitability. They recognize that it gives them a competitive advantage, and that they can expect greater productivity from the workforce. And it is demonstrating to them that there needs to be a shift in their thinking and an embrace of other sectors in order to make this happen. We know that cities like Rochester have come together across sectors and committed to making their city one of the healthiest in the country because they knew that it would benefit the people and business and would also reflect well on government. So just to underscore your point, it takes all sectors.
Adrian?
Our experience is that if the employer and the CEO and the leaders of the company are focused on prevention and promote it, the effects on the employees are dramatic. And I think that's something that we have to really push quite hard going forward. It's interesting that if you look at the governance codes, whether it's sustainability reporting here, King in South Africa, our country, or Cadbury in the UK, there's virtually no governance requirements about reporting and wellness and prevention. There is in terms of sustainability around climate change, etc., but it's one of their missions, I think, and to an extent that I think if companies report on the wellness activities that they're doing in a bit more detail, I think we'll get a much greater force on pushing down to employees the effect of prevention. And our experience is that, as I said, if employers are committed, the effect on the employees is dramatic. And I do think from our data, the return to the companies over time is dramatic.
Risa, do we have any companies in the United States that do a health and wellness report? Or included in their own report?
There are a number of companies that have made strong commitments to wellness. Companies like IBM, Dow, Johnson & Johnson. There's actually in the Dow Sustainability Index some information, some variables that companies can track along health and wellness. So one of the things that we might be able to do is to increase the visibility and the focus on some of those variables within indexes like the Dow Sustainability Index.
That raises a larger question of metrics. At least in the United States, we have a sort of obsessive focus on body mass index as sort of a snapshot of risk factor for, diabetes, heart disease, a myriad of non-communicable diseases. Is that what we should be overly focused on? Should we be also focused on other metrics at either the individual level or the family level or the community level? Please.
Chelsea, metrics is extremely important because without metrics, you cannot measure progress or lack of progress. But I like to pick up on the point you talk about body mass index, BMI. The BMI that is applicable for, Western world may not be applicable to the Asian society. We notice that in many Asian population, including China, India, and we just heard about the diabetes situation in India, you don't need to be very obese, and you can get into problem with pre-diabetic conditions or diabetes. So depends on, where are the data sources for the body mass index. So what is useful, applicable in the States may not be applicable for the country. What I'm saying is that you do need country-specific data in order to help people to say, okay, is this a good measure for me to pay attention to? So metrics is important, but...
I must agree. I think if you don't measure something in a verifiable way, I think you get lost. And I think it's critical, certainly for companies, to understand.
Do you measure either different variables or the same variables in different ways, or do you have different risk thresholds in the UK versus South Africa, to Dr. Chan's point?
We measure engagement across every single aspect. So every time people go, and whatever activity they do, they earn our vitality points. It's like a currency. So everything is measured and verified. But the measure we use that I think has some great value generally is the idea of a we call it a vitality age, but effectively your risk-adjusted age, taking into account all the factors that you have. So I'm 49, say. I am 49, but so based on my risk factors, I may be 58, right, from a mortality perspective. Knowing that as an individual, that I'm actually 58 from an actuarial clinical perspective, that's a composite measure. It takes all the risk factors into account, but it's highly emotive and it changes behavior. So I think that takes into account BMI and all the other aspects into one, I think, clear message and one measure. And to me, that would be much more powerful. The other point I'd make is that understanding the ROI on these initiatives is fundamental. It really is. And I think the measures we're using at the moment, the methodologies, are really nascent. They really are basic at the moment. 1 year's cost versus 1 year's benefit. Whereas I think with prevention, the trigger events like physical activity, I think when people become physically active, there's often a change of life completely in that respect. So you need to look at the present value of the saving over time versus the cost initially. So to an extent, I would argue for a simpler, more emotive measure that's composite, and I'd argue for an approach of looking at the benefit of this intervention in a much more sound way that we can demonstrate properly to society.
What is the average delta or difference between the actual age of your enrollees and then their risk-adjusted age?
Interesting. In a number of countries we've done this kind of research. We found it's typically 4 years. So society on average is 4 years older than they theoretically should be. And that's quite a big gap. But when people find out that they're 65 years old actuarially and they're actually only 45, it's amazing the shock that you get and the change in behavior that you get. So it offers two benefits. I think it offers a proper sound measure. On the other hand, it kind of creates the behavioral change often that you need.
Risa?
I think it's incredibly important for us to have metrics at the individual level and to measure how companies are doing. But we also need to have measures at the community level. Read that as counties and states. There's measures that we know we have at every county in this country And when you present leaders with how their county is doing, it is a motivation for them to improve that and to come together and try to improve it. So to your point, we aren't going to change what we don't measure, and we need to make sure we've got credible metrics that are based on good science at all of the levels and across all of the different dimensions that we need to change. And that's county, state, companies, as well as individuals.
A different meaning of healthy competition. Dr.
Yes.
Chan.
I see the change in the acceptance of using data to drive action. 10 years ago, WHO produced a World Health Report. We ranked all the countries' health system performance. You should see the reaction. Very bad, negative reaction. Countries just don't accept being ranked. But now the society has changed. You know, social media, ICT, the power of ICT, etc., etc. Here today we are in, of course, the UN General Assembly. One very important issue we are talking about is the importance of to fill the data gap, invest in collecting good data, doing good analysis, and then to document progress or lack of progress, and hold government and other actors hold their feet to the fire. Because it's easy for people to stand up and make commitments, whether or not they walk their talk. The job of civil society and academics is to make sure that, you know, we don't walk away from our commitment. Now, that's also the mutual accountability is becoming very acceptable now. Exactly what Risa was saying. If you rank them, leaders don't like to be at the bottom of the league table. I mean, it provides them with the political energy really to take action. So data is important, measurement is important, what gets measured gets done, and that provides the framework for transparency and accountability.
Well, we are big fans of accountability here at CGI, also of transparency and of data to enable the accountability. And we commit to having NCDs be more a part of our work here and more a part of our continuing conversations with all of you. And I want to thank all of you for the conversation today. Thank you very much.
Thank you.